So if you're going to do a body drag where you have somebody who's laid up onto a towel, this is a makeshift sled of sorts. And what we're trying to emphasize in these series of pictures is that you want to make sure that you have your back in an upright position and then use the lats to kind of pull or drag. We never want to use the lower back to be the momentum providing function for moving that patient. And then make sure that you're trying not to twist. Again, the spinal column is really pretty durable so long as the load is being applied on it axially. And we're going to beat this one to death. So moving a patient across a bed, we want to make sure that we're up on the bed, kneeling next to the patient to avoid that reaching and torque multiplication. And then complete the drag when you get to the side of the bed. Get off the bed, stand up, and finish your move. If you have two rescuers, then you can have one on each side pulling the patient in the direction of travel that we need them to move to get them safely moved on to another device. Log rolling a patient, the only thing I want to keep in your guys' viewpoint here is it's really actually kind of tough to see this from this picture. But if you look at the female who is being log rolled, you can see that the arm underneath her head is pulled out so that her head is actually resting on her upper arm and shoulder. And this is going to help keep the head and neck in a midline position, and it's really more comfortable for your patient. If you guys want to practice this, go ahead and put each other on the ground and roll you up onto a arm that is tucked underneath your side, and you'll find that it's not very comfortable, nor is it safe. It'll only take a couple times of doing that, and you guys will kind of see the value or the merit in pulling that support arm at the base out. So when it comes to gurneys, we want to make sure that the gurneys are moved the same way that we were talking about moving a patient on, say, a mega mover. It should always be moved feet first. The patient should see where they're going if they're sitting upright, and we want to make sure that we're protecting them. If anything's going to be in the line of injury, it should be the farthest away from the skull or the chest cavity as possible. We want to keep the feet moving forward. And the person who's generating all of the movement when you guys are moving a gurney is going to be the person who's at the head. They're the engine, and the person who's at the feet is controlling the direction of travel. So this is labeled emergency moves, and you can see different types of grabs and drags, the closed drag, and this is going to take some, probably some good thought process. This is obviously going to be dictated by what the patient is wearing and what you have available to you. And if you have to do a blanket drag, they obviously have to be on a blanket, or you have to somehow roll them onto it. An arm drag is always available to you if they obviously have both upper extremities, although it may be difficult to grasp the wrists and use that really large kind of grip to get them anywhere. The arm-to-arm drag is another likely position that you could end up in, but generally when I'm looking at these pictures, I'm looking at somebody who has to move somebody for a life threat that's immediate, and they do not have the assistance. In any case, you should have two people. All right, in these pictures, we're going to try to emphasize what would probably be appropriate for one rescuer drags, carries, and lifts. I would suggest that if you're looking at the fellow there on the left, that you are looking at the guy here in shorts, I should say. That's probably not something we're going to see a lot of people do, and if we do see that, I'm hoping that that's a very small person in stature comparatively, or a child, and still probably not one of the better things for us to try to practice. You can see the hands tied around the next gentleman's picture, where he has the hands basically cuffed with what looks like maybe some Curlex around his neck to get her into a upright position so that he can fold her up into what we would call a fireman's carry, which is placing her around his shoulders. I've not ever seen that done in the field, but it is actually a fairly easy move to pull off by yourself. The last picture, which would be on my right as I'm looking at this, is a one arm around the neck, kind of like a drag assist carry. And that's more for a semi-conscious patient who perhaps is really weak or unable to move, but you need to move them pretty quickly. They should be able to generate some of their own power. Now these are all urgent moves, and they're necessary when you need immediate life saving. And this is like something's about to burst into flames, and you cannot wait for the additional help. Now, I definitely don't agree with the examples included being altered LOC, right? Yes, if you need to move them, and if there's just no way to get them to where they need to be without waiting for that extra stuff. Extreme weather conditions may make a move urgent, but I wouldn't say that it's urgent enough that you really have to do it by yourself. If at all, please keep in mind that you should always have at least another person to help you distribute that load, unless your patient is really small in stature. Okay, rapid extrication techniques. And this is for patients sitting in vehicles. You can move them within a minute. This is what we want to call snatch and grab. It's not really done very often. Again, this is probably a life-threatening movement. And we're making that decision because something is going to cause greater harm or death if we do not get them moved. Non-urgent moves are obviously our bread and butter. This is what we practice day in and day out. There's multiple personnel. You've defined what your obstacles are. You plan it out. You have your equipment staged and ready to go, and you know that you can follow the path that you have set up. Make sure that you're choosing between whether or not you're going to do a direct lift or an extremity lift. And obviously we always want to make sure if we have enough people there that we can distribute that, and we want to get them in a lift that's most comfortable. And that means trying not to grab them from the wrists and the ankles. We want to get close to their core so that we can get the majority of their weight up without creating extra strain or stress on their body. And then do we carry them basically body contact to body contact, or are you dragging them with the sheet? And or using the backboard scoop stretchers or your other devices. So when we're looking at geriatrics, and this doesn't necessarily have to be old people, but you're going to see this more in an elderly population. As people age, there are things like osteoporosis and other things like kyphosis that you see in the spondylitis. These are extreme curvatures of the spinal tract. And that person is quite literally locked into that position. This is not a soft tissue kind of situation. Over time, the bones have basically formed into a position where they are no longer able to straighten or use their full range of motion. And so putting these patients on a backboard is almost impossible. And really, it's downright torturous for them. So if you have that patient, which, again, is really significantly seen in the elderly population, you want to make sure that you're taking due regard with their care. You want to keep them in the most comfortable position while maintaining their safety. So again, if you have to have that person on a backboard momentarily, and there's just no other way around it, you can do that. Just make sure that you're supporting them and patting them appropriately to take pressure off of them, because that's a very uncomfortable way to be. And if you're laying them on a very hard, flat surface, you're going to create extra pain. And these patients will degrade skin and other soft muscle tissue with that pressure in a matter of minutes. What doesn't look like an injury to you right now can quite literally become an ulcer in just a couple of weeks later because of the tissue necrosis from that pressure point. This is just hammering home what I said about the kyphosis and how we can actually further or exacerbate injuries when we have patients who are on backboards. So please treat them with compassion. Make sure that you pat it and get them off of something hard, flat, and rigid as quickly as you possibly can. We're going to touch on some bariatrics, and I think the latest stats, this might be a little bit old, is we're nearing 40% obesity in the US, and this is saying 100 million, so it's close, but not really quite where we're at. And there are a couple of ways to define what we call obese, and we can use BMI or body fat, or ideal weight versus regular weight, right? Anything at a BMI of 30 or above is considered obese, and obviously as it goes up, it is morbidly obese. But most people are just a little bit overweight in the US. It's probably much higher than the 40% for obese numbers, but Regardless, we're going to talk about how to manage these people and how we're going to move them, because we really don't want to create these noted missed days of work. And again, if you really want to know what's going to cause you to finish your career physically, it's going to be a back injury. Very rarely do you hear about people with a sprain or a strain to an ankle or an elbow, like never returning to work. But very often somebody who injures their back, that ends up becoming a lifelong nagging or persistent injury, and they are unable to actually perform the duties that are demanded of them. Stretchers and equipment are being produced with higher capacities. We see that all the time. Hospital beds are wider and bigger, wheelchairs are wider and bigger, and gurneys are getting wider and bigger, all the way to specialized bariatric gurneys that can withstand upwards of 12 to 1,500 pounds. That doesn't mean that just because the device was designed to carry that kind of weight or load, that it's still any more safe for the patient or you. So make sure that you have the absolute maximum manpower that you can manage and use functionally. Here you can see the bariatric stretcher. What I don't like about the picture in this is that the stretcher is in upper position. Anytime that we're moving a bariatric patient, they should be in a lowered position. That's why you see the handles that are at the foot and the head. And that's so that the patient can be in a low position, because that's a low center of gravity. They're less likely to tip the gurney, and you can push, move, and manipulate the gurney with the handles. So this is a folding stretcher. It's just some plastic wrapped around a frame that has a couple of folding points and a couple of buckles, and I really don't see these in the service very often. This might be more like a ski patrol situation, or something where somebody has to be able to pack this in and out of a long distance kind of rescue situation. All right, so this is the flexible stretcher. We call this a sked in our service, and this is actually a really nice tool. It's very slick and can be easily dragged across the ground, which makes patient movement with just a single rescuer pretty easy. We'll often use a piece of rope and get some knots tied into the head of it and get the patient drug along that. As you can see, they've got this folded up and secured around the patient, and they're using it on some kind of rope rescue hoist system. Now we have the standard backboard and the KED. One more time. We will not be testing anybody on this equipment, but I am happy to familiarize you with it, because most services still keep it on the truck, even though it's not widespread or being used at a very often pace anymore. It is still something that I would say is a good skill to have, although not required or mandatory. So this is a basket stretcher, and this is kind of like a backboard. It's a little bit thinner in nature, and you can see it's kind of got a lip or a rim around it, which is a little bit more capable of keeping a patient confined and less likely to let them slide or slip off of what we would consider the backboard portion. And as the picture is insinuating, this is for kind of like a hazardous area where we may have the patient moved at weird angles, or having to change elevation, or around any kind of brush or debris or other obstacles. It's a scoop stretcher, and it quite literally does what it says it's supposed to do. You can fold the small scoops, and this will actually slide and kind of get underneath the patient, much like maybe a spatula coming in from both sides. And this is for the patient that really cannot tolerate any of the movement or the log rolling. So this is a neonatal isolette. This is what neonates are placed into. It's kind of what we would call an incubator in the hospital, and it's to keep the baby warm in a climate-controlled condition. As you guys are probably aware, babies will lose tremendous amounts of body heat if we do not keep them wrapped up. Any kind of convection will actually strip too much heat away from them, and it actually puts them at high risk. So what we do is we put them in the isolator, and that isolator actually clicks into a specialized gurney or a specialized transport unit in the back of an ambulance. And again, this is really to keep them warm and in a protected environment. And sometimes it may be so, isolating that it will have its own oxygen supply and keep any kind of germs or bacteria away from the patient. Much like anything, you want to make sure that you decontaminate your equipment after use. And this means that after we get done with a patient, we should wipe down the gurney, the rails, the straps, and the padding that would be underneath the sheet. One of the things that we always want to make sure that we remember is that it's not necessarily for us with the intact immune system that we're really concerned about, although it should be a concern. It's about spreading disease to other immunocompromised patients. So make sure that you're practicing that cleanliness with your equipment, and don't just kind of look at it and throw on a gurney sheet or kind of throw your stuff back into your bag. If you have the time to decontaminate it, get it done. I mean, it's only good practice and good form for you to protect your patient as well as yourself. So this slide says medical restraints. Now, unfortunately, the protocol for AEMT is not to be able to use any of the barbiturates or sedatives to try to get a combative or injured patient into a compliant position. That is a little bit more along the lines of what's popular these days, is to use a chemical restraint, because it is somewhat humiliating or degrading to somebody to have them completely subdued and restrained physically, and that's something that we should avoid at all costs. There are those cases, though, that we're going to have to restrain a patient because they are combative or unable to comply with our commands, or they're just dangerous to themselves or us. So we want to make sure we're following those local protocols. If you do not have the ability to use a sedative to maintain some kind of control or to calm the patient down, follow the protocol for your restraint process. This usually requires that you're going to have multiple people to get that person subdued and get the restraints on them. And you want to make sure that they're face up. We never restrain somebody face down, and we want to make sure that every extremity has a restraint to it, and it's placed into a position that does not allow them to get to the other restraint or to injure themselves. This is some questions that they want you to consider before you do this, and I think this should be a no-brainer. And the first one is going to be, am I physically strong enough to lift or move this patient? And even if the answer is yes, the next question should be, do I have enough people to help me to make this easy? We should never really be taxing ourselves or putting ourselves in a situation where we're using all of the strength that we have with 0 left in reserve to move a patient, unless it's truly a life emergency. And again, this is saying, remember that if you're injured, you can't help anybody. So again, I really want this to be a short and sweet lecture. I hope if you guys have any questions, we can have a conversation about it in lab. We can practice any of these skills if you would like to. I encourage everybody to stay physically fit and understand their limitations and really think like a process out before you begin something. In class especially, I do not want to see anybody injured because they're horseplaying or over-exceeding their capabilities. So as always, if you have any questions, please email me or follow it up in the discussion board and discuss amongst yourselves.